Okay, welcome back, everyone. Health equity, as you know, is not possible without effective collaboration across different spheres. So for this next portion of the conference, we'll hear from a multidisciplinary panel of experts. Our distinguished panelists have a unique mix of professional and personal experiences, and collectively will be able to provide a comprehensive insight into the current landscape, and solutions to address these gaps in maternal health. Dr. Irogue Igbinosa, known to us as Dr. Iro, is an obstetrician, gynecologist, and maternal fetal medicine practitioner at Stanford. She received her medical degree from Baylor College of Medicine and completed her obstetrics and gynecology residency at Louisiana State University School of Medicine, Baton Rouge. She has served in the CDC Emergency Operations Center as a public health policy fellow and contributed to research regarding the management of Zika virus in pregnant persons. Dr. Igbinosa's current research interests include severe maternal morbidity and mortality, health disparities and equity, anemia in pregnancy, infectious diseases, and clinical trials. Ms. Alma Burrell is Chief Administrative Officer for Roots Community Health Center, a nonprofit health organization that is committed to serving the most marginalized and underserved in our communities. Prior to her position with Roots, she managed a variety of maternal, child, and adolescent health programs for the Santa Clara County Public Health Department for nearly 20 years. Ms. Burrell has spent her professional career advocating for families, assessing community challenges and supports, and designing and implementing programs that support health. Ms. Burrell received her Bachelor's of Science and Master's of Public Health degrees from San Jose State University. Go Spartans. Leilani Michelle Jones, okay. Leilani Michelle Jones studied ethnic studies, organizational change, and sociology at Northwestern University and has worked as a researcher, project manager, and consultant for several organizations in the DEI field. She is the executive director of Health Equity Learning and Development within the County of Santa Clara. Partnering with communities and underserved populations has provided her with the skills to make connections with others and use that connection to foster learning and engagement. Ms. Jones is well-versed in working with organizations to deepen their connection to communities and partners to advance growth, development, and equity, and has strong expertise in community-based participatory research, team development, organizational change, and strategic planning and implementation. So please give a round of applause for our panelists. Okay. We'll get started with our first question. And I'll also note that for the audience question portion, it will be similar to that of it was the prior presentation, where we're just asking you to write your questions down, raise your hand, and someone on our staff will grab those. So our first question, and open to any of you, what are some strategies of improving our current system to decrease disparity in maternal outcomes? And I know this whole conference is about that, and we've talked about some that we're doing here at the County of Santa Clara Public Health Department. But if you all have any strategies in particular that you'd like to speak to that you're quite fond of or supportive of, then this is the space to do that. So what are some strategies of improving our current system to decrease disparity in maternal outcomes?
Happy to jump in to start. I would say start working. We've done enough studies. We have enough task forces. We have enough committees. We have enough work groups. Let's get to work. We've heard 1,000 times over what needs to get done. I have, when I came to the county, a cabinet full of binders, full of strategies that community members have told us will work. So I would say, let's start with working.
Absolutely.
I echo that, and I think what I would add is data. As we saw today, how powerful data is, how powerful it is when we see it in a national aggregate, and then when we disaggregate that by race and ethnicity. So an overall percentage for national, when you look at pregnancy-related mortality, that would say one thing. You saw 17 or 32 from 2017 to 2021, but then when you separated that by African American or African ancestry, we saw 40 deaths per 100,000 live births than to 70. And so that data is so important. And then I want to echo Dr. Boyd, addressing structural racism is such a key thing, and how that manifests in our work is that what policies are causing disenfranchisement. And so she mentioned, the universal drug screen at some places. I was at an institution, not currently, that we did screen everybody. That just happened. And then there had to be very intentional changes in terms of our hospital culture to eradicate that. And that's just one example. There are many other examples that if we look at our policies, what are we automatically doing that we don't have to?
Okay, can you guys hear me okay? I would just say that we really need to really take this home when we get off work. Like, not think about this issue as just an issue we deal with when we're at work, but actually take it home. And when you see young pregnant women of African descent, with the knowledge that you have, provide some concrete protective factors. I mean, there's just simple things that we can do that can help people, because we are the community. Everyone in this room, you are the community that our women need, that our birthing people need. We're the big mamas, we're the aunties, and we have to take this home, and we have to do this on a daily basis, and not just think of it as something that we're doing when we get to work, but something that we do every day. It has to really become a part of us for us to begin to see a difference. It's the little things that we do that make a difference in people's life. And I'm just gonna say one more thing. I'm saying little things like they used to tell me, honey, sit down, you've been standing up for too long. You need to just sit down and take a rest. Little things like that make a difference, adding those concrete protective factors. When you go visit someone that's had a baby, don't just sit and hold the baby, get up and wash the dishes. You know what I'm saying? Right? When you see some young woman that's carrying a heavy load, hey, pick it up. Ask someone else, ask the young man, someone else, hey, pick that up for her. She shouldn't be carrying that. Just showing that love, that concern, those protective type factors, those are the things that help us to birth healthy babies. I'm done preaching.
Wonderful, wonderful. So our next question, and again, encouraging folks in the physical space and the virtual space to answer questions, all things health equity. We have a multidisciplinary panel here that can answer those questions. So I'll ask next, to what extent should midwifery care be incorporated into our current system? And what are some ways to do so? Where to start?
Does this work? Oh, okay. So I think it should be incorporated more. And I think, I like to talk numbers first. And so when you look at midwifery statistics, they usually give it per 1,000 live births. And so in countries with similar resources at the US, for OB-GYNs, there's about 11 to 16 per 1,000 live births. And so then when we look at other countries like France, how many midwives do that have for that same number? They have about 30. Australia has about 66 or more. And then in the US, anybody want to guess how many we have per 1,000 live births? We have 4. Right? And so just in terms of access, right? And so what is our access? I think most births, don't require a high, aren't complicated, and so how do we support people with just, uncomplicated births, and so that they're getting, more comprehensive care models. And so I think midwifery care should be supported. And that's a whole discussion in terms of why there are less choices available, like historically, who used to be the midwives for Black birthing communities, and why that disenfranchisement is intentional. But I think that ways to support it, that could be done amongst all of us in terms of like increasing access to care.
Oh, I would just say it makes sense economically for hospitals to hire midwives and to make them more available for women for uncomplicated births. And I know that in our systems, we look at numbers, we're a number system, and that is one way to care for women, to get more individualized care at a lower rate.
And it's for anybody also, what specific recommendations do you have for collaborating across departments or sectors? So here we have, county government represented, also, a private institution, a hospital, and then also a CBO. So what specific recommendations do you have for collaborating across departments or sectors to work towards birth equity?
I can start from the government perspective. I think when we go to community-based organizations and ask them for assistance or partnership, we need to be offering something to community-based organizations. And more often than not, they don't need our expertise, they need our money. So if we're coming and asking for volunteers, don't. We need to pay our community-based organizations what they're worth because we need them more than they need us.
Amen.
And so a follow-up question, can you share any specific examples of successful collaboration between administration, doctors, and community in kind of providing that whole person care for our Black pregnant and postpartum community members?
All right, here we go again. So one of the things that we've done in the year that our office has been here is that we had a community connection day between Roots and our labor or our OB-GYN department. And so it gave the staff at our hospital, staff and physicians, the doulas, the team at Roots, an opportunity to meet each other, understand each other's philosophies, care models, and also make sure that the doulas had seen our hospital before, had known what it's like to navigate our system before, so that we're not asking the doulas to come in and accommodate us, right? So I think that was really impactful. But in terms of successful partnerships, I really think PD Power, our pediatricians, organizing and working to end racism, that group should be a model for our entire country in terms of what it looks like to really dedicate yourself to the people that you serve and the most marginalized. But again, we have to positively reinforce that. We had an event last night and I talked about organizational culture, and we say that word a lot, especially when you ask a company around or an organization what they're doing around equity. They start throwing the word culture around left and right. And what does that even mean, right? What is your organizational culture? I would define that as behaviors and practices that are reinforced, either positively or negatively. So PD Power is doing amazing work. How is that positively reinforced by the system? Not via recognition by our supervisors, which is important, right? But every day, how is that reinforced for them? All of the time that they're dedicating, their labor, their emotional labor, how do we continue to positively reinforce that so that other departments can do it too? Because they're not the only department that's interested, right? There are lots of people across the system that are interested, but we have to build an infrastructure that reinforces it. And I think that we have leaders that do that, but it has to be a part of the policy. Like if all of these leaders were replaced tomorrow, would it be the same way, right? So I think that's the question we need to ask if we want to see those partnerships continue.
And I can add that, we've seen it. I know we'll hear about it later about like the low dose aspirin campaign and how just from there's an issue, but then we engage with community groups first in terms of forming the question. We see that with the research, and then how does the actual intervention take place? And so there are a lot of examples maybe in terms of centering. I think that popularity has increased because, again, hearing from the community that is what they wanted. And so hospital care systems kind of, modifying their offerings based off of what community input they're receiving.
Absolutely, yeah, centering is a great example.
I forgot to add another one because Michelle Ferreira is here. And we have an O'Connor team that has a group that's working, and they're here, and yay, let's give it up for them. And they are working constantly in partnership with Leslie from our team, who's also a doula. So hi, Leslie. And doing amazing work and identifying really significant interventions to reduce disparities in our care. And so I wanted to raise up that group. But again, I think we have to positively reinforce these groups and create space and time for that. But there are groups here doing amazing work. We just need to figure out how to make that not happenstance, right?
This is a question about, we talked a little bit about accountability, systemic accountability. What metrics can be used to track accountability of the system, including care providers?
So I think that's a good one. I think, so one, we look at outcomes, adverse outcomes. And so I think CMQCC, the California Maternal Quality Care Collaborative, is a really good example of that. Where in terms of their data center, they have the hospitals who voluntarily are sending that information for tracking. That is not something that is, in terms of federal reporting about maternal mortality review committees, only about 36 states participate. So it's pretty novel that in our state, we're getting this kind of voluntary participation from all these hospitals. In addition to that, I think in terms of metrics, we also need patient-reported outcomes. And so when we saw the slides, they were really about something that happened to you. So either it was a death or an almost near missed event. But what is important to a patient? What else is it? Is it how did I feel when I came in? Was it satisfaction? Did I feel like I received the full range of obstetric birthing options? Like those different metrics, we don't actually have a great way to measure that. And I don't know if you guys have seen, but the U.S. News World Report released just yesterday a new ranking for Black maternal health excellence of hospitals. And there's about 5 hospitals from California who made that list. And the question I had, I was like, so what metrics were used to define that? I'm not, hating on this system, but I was just curious, like what metrics? And basically it was C-section rate. What was a C-section rate? Whether you were a low or a high risk hospital was at less than about 23%, but it was about outcomes that were really about kind of delivery related outcomes, and you could counter, but where is the patient? And so I personally am a big advocate that you have to have both. You have to have the data in itself, it shouldn't be biased. Numbers are agnostic, but you need a patient component voice. And so I think the combination of the two is what's important.
I'll just add to that and say we cannot discount qualitative data and self-reporting, people telling us exactly what is happening and what they see as a problem, and their personal experiences should be highlighted. I just recently returned from a cruise. Any of you guys ever been on a cruise? My God, when I got back, I got a survey from Princess Cruises, right? And because of my background, I usually take surveys. I usually do them. That thing went on and on and on. They wanted to know about every single thing. How was the dining? How was it this? How was it that? And I don't understand why we can't do the same things, because these kinds of businesses are constantly improving themselves and constantly finding ways to better serve you and make you feel special, make you feel welcome, accommodate your every need. And I don't understand why we don't take the same kind of approach, right, to make sure that the patients that we serve are getting the things that they need so they can have those same kind of outcomes, right? We call these folks hard to reach, but Coca-Cola doesn't call us hard to reach, right? they're able to reach us. There are methodologies that are already out there that are proven that will give us the data that we need to make the improvements that we need to make. I think we just need to model some of these other entities, the way that they do things, the way that they market themselves, and the way that they find out, get to the heart of the crux of what we need and what we want. We can do the same in our hospital settings.
I'd add that we need to focus a lot more on the well-being of our staff and our physicians. There's a direct connection between the well-being of our staff and the well-being of our patients and their outcomes. And so in our OB-GYN department, there are so many rock stars, Dr. Mahari, Dr. Isquick, Dr. Sanchez, so many people who are so great. And also those rock stars are everywhere, right? I was on a website for Amigos de Guadalupe and I saw a picture of Dr. Sanchez and I was like, what doesn't she do? She is literally everywhere. But that's the problem, right? We have these rock stars who emerge, who do everything for everyone. They get burned out and then they leave. And so we have to look at things like, if we're saying that we want cultural congruence, we want racial ethnic concordance, what is the rate of separation by demographic of our staff? If we look at the county, Black women are most likely to leave, right? Earliest. I think something like by 1 year, 20% leave. That's a really significant problem, right? And then you'll hear the story of, well, this person was a problem in this way, this person was a problem in this way. Everybody's not the problem, right? At some point, we have to say there's a systemic issue here, right? So I think we need to do more of that to make sure that we're retaining a diverse set of committed physicians and staff in order to see more improved outcomes.
You know, the other thing is that I think that we need to extend our recruiting, right? Often hear that, you know, well, we put the recruitments out there, but we don't have that many African ancestry doctors or physicians, or, you know, or whatever medical, we don't have enough in the medical pool to choose from. But I think we need to extend our recruiting efforts. There are universities that are turning out some fabulous doctors. I mean, Howard University, Meharry University. There's places that we can go, that we can find folks so that they'll look like the folks that we're serving, which is super important. It's very important.
That is actually a great segue to the next question. How can researchers and teachers in university settings serve as effective partners in service of the reproductive justice movement?
That's a loaded one, but I'll take it. I think, you know, when we say diversity, and, you know, I do want to acknowledge there isn't a national attack on diversity, equity, and inclusion and how that is defined, right? And so, and that we are actually fortunate to be able to openly talk about it in this forum, whereas other people have already started to rebrand how they talk about DEI. And so I say that to say that we have to really think about that inclusivity in terms of research and academic spaces, as was mentioned, is like how, when a patient, we think about it from a patient, when they arrive, who do they see that looks like them, with the representation? And it's not just a physician. There's so many other roles in the healthcare system that could be more diverse. But in terms of the framing of your question, the reproductive justice framework, especially when we think about the kind of onslaught on abortion access, and I think one is the education. I think we're very familiar with what the issue is, what the plight is, but everybody isn't. You know, in terms of reproductive justice, some people may not understand how that is an intentional reframing from moving from a pro-choice conversation to the right to decide whether you want to have children or not, the right to decide how you want to raise your children, the right to decide what resources and accesses your children have. So it moves the conversation from a one-time event, but towards a lifetime, like what do you have access? And so in terms of that education and partnership, the founders of the reproductive justice movement are still with us. They offer actual teachings, they have frameworks, qualitative and quantitative, that has shown how if you allow them to come into your spaces and partner with them, that they can collectively elevate the system. And, and they've shown that how when, for example, Dr. Loretta Ross has recently spoke on how she's worked with the Planned Parenthood, that how, their teachings have kind of infused how Planned Parenthood is giving some of their messages. And so the partnership from an academic space, we've heard a little bit about the power exchange, and I do think it's so important that when we're coming from big resources, resource centers, that we realize the power is actually in the community. Like the solutions have already kind of been presented there, and we're just hearing of it, but we may have the power to amplify it. But in that amplification, that we're not taking away ownership of that message.
So we've been talking a bit about data, and then, kind of it brings forth that saying that we cannot fix what we do not measure. And so this question is for everybody. What constitutes, in your experience, the barriers in hospital data transparency?
Has anyone tried to get their medical records? It's often not in one place, right? So you went to one system, you get one place to get your, mammogram results, if that's what you did, or one place to get the doctor's note, another place to get your labs, another place to get your pharmacy notes. And that's if you went to one place. Maybe your system talks to another system, maybe it partners with another hospital, maybe you went to ER or transferred. And so all these different things are barriers then when we're trying to talk about how do we actually pull that information from the data to analyze it. There's all of this big data, but in terms of how it's not uniformly collected. So one person may say you have type 2 diabetes, one may say you have diabetes, one may say pre-gestational diabetes, one may just say the A1C was elevated. Again, in terms of pulling all that information together, how do we make it uniform? So these are just some examples of how it can be really hard to pull that data to actually understand what's going on. And this is where one of the few instances I'm a fan of AI in terms of language processing models, in terms of, everything else. I'm like, it's a human connection here. But here you have this big data. We're trying, everything just gets scanned in different places. How can we actually get this data? And I think that is actually one of the hugest barriers. It's not, in terms of reporting out of the data, it's not uniform in a healthcare system. It's not mandated a certain way. So there's just so many individual interpretations that can occur. And so these are just some examples of why it's so difficult to get data.
I would add that hospitals and government institutions in general are risk averse, right? So I would recommend to be solution oriented here. A redefinition of what risks are. I would argue that allowing inequities to persist is a huge risk to a system, right? A financial one, a moral one, all of the, and so on. So I think we can think about risk differently in terms of showing data that maybe is not favorable to us, so that we can actually start thinking about improvements in partnership with others. It's going to be really hard to partner with communities to fix problems that we won't fully disclose to them.
The other thing is, I agree with my sisters here. But the other thing I think what I've just noticed is there's a lot of resistance to collecting this data because the technology is there. It's difficult, but it's not impossible to gather all of the data that we need. But when you discover a problem, then a solution is expected. You're expected to do something about it. And so it's easier to just say we don't have a problem than to actually go digging around and finding the problem, right? And so I think when we can change our the framework of our thinking to not, this is an issue, but this is more of a challenge. This is something that our hospitals want to tackle. We want to do better, and we not see it as a problem and take it negatively, but as a challenge for us to make improvements.
That reminds me, I was just having a conversation with Dr. Byrne, and we were talking about if we thought we had no problems to fix, then we'd know for sure that we do.
And then I think to follow up to that, I wanted to share, like, I agree. Like, I feel like it's we should find what, we are in a very resource area that we can find solutions, and so we should. But then also, just again, on the patient side, we've seen like the development of like the Earth app, where women are like not waiting for the hospital system to figure it out, but they're, you know, curating their own information and own experiences about their hospital experience. Like, did this hospital offer you this, et cetera, et cetera? And they're rating their own hospital experiences, and that's available. And so there's this disconnect. And so I agree with moving past the barriers to solutions.
Absolutely. And very quickly, we're going to have Christina Oldini, who is the Associate Director of Programs for the California Maternal Quality Care Collaborative, CMQCC. And this is on the topic of what constitutes the barriers. in
Hi, good
hospital.
morning. Just a remarkable day, honestly. I want to make it clear that other than patient protections, right, data protection on behalf of patients and clients, hospitals are able to share their own data. It is a choice. It is a choice. We are happy to assist them, to support that work, and to bolster it. And I want to make that very clear. And all patients have the right, the power to ask any clinician, what is your data regarding this? What is your data? What is your C-section rate? How do you, how many women of color do you care for? All those questions are normal questions, are average questions that a clinician should be able to answer.
Perfect. Thank you so much for that. Okay, so I think we'll do maybe one more question from our prepared batch of questions, and then we'll turn it over to some from the audience. How do you envision the future of maternal and infant health advocacy, particularly in terms of dismantling systemic bias? So how do you envision the future of maternal and infant health advocacy, particularly in terms of dismantling systemic bias?
Wait, I'm sorry. Okay. I think it is it's a hard question, but I would say it involves everybody. I don't think there is one group that can eradicate the disparity alone. And I think sometimes when we promote one solution over the other, it puts an undue burden on one group or one group of professionals to feel like they have to come in and rescue something that is structural and systemic. And so I truly think that it is a partnership. And the key that I think is who we partner with. We should, you know, be nimble to think about, are we being more innovative with our partnerships? So beyond the traditional academic and maybe public health spaces, just like this room is evidence of community partnerships, maybe even private sector partnerships, right? There are other stakeholders. We talk about patients, but patient groups. And I think we can kind of go, when we talk about health professionals, maybe other allied health professionals like social workers. You know, we've mentioned that the disparities can persist despite social determinants of health. However, social determinants of health are still an arbiter of disparity. And so we need help and resources in addressing those disparities. And that comes from our social workers, our counselors. How are we supporting people? And so I just think the partnership is the way that we will get to addressing maybe a future where we're kind of closing, narrowing and maybe eliminating the gap.
I can say that I am so hopeful, and I think we are at a really good time. I've been doing this we've been in this business, for 30 years, longer than some folks have been alive. But this is to me, it's amazing that we can sit in a forum like this and talk openly about injustice and racism and prejudice and equity and all of that. We have come a ways, guys. There was a time when these conversations only happened at the kitchen table amongst families. So I'm really hopeful. I just don't want us to allow others to reframe the conversation. I think my sister said it earlier. We cannot allow this conversation to be reframed. We have to stick with it, pedal to the metal. We got to put the pedal all the way down and keep pressing and keep advocating, because we've come a ways. And this kind of conversation among among all of you, this is what makes the difference and begins to open the doors for us. So keep going, full steam ahead.
Yeah, to that end, I would say often when we have these sort of campaigns, these big movements, they become sort of euphemisms or metaphors, right? We saw that with, dare I say it, Black Lives Matter. We see it become sanitized, right? It becomes easier to digest, and then it becomes further and further away from the initial intent. So I think having leaders, I personally have had a really positive experience with the head of OB-GYN here in terms of getting data, in terms of being able to do a community connection day. Do you think that I haven't seen at other hospitals when I was working? So I've been really grateful for that. And that's not to say that there's not work to do. And also having leaders like Supervisor Ellenberg, who's sitting here through this conference, not just showing up when it's time to speak and leaving, right? Actually sitting here with us, being in conversation. So I think that if we are to progress forward, we need leaders like Jim, like Susan, who are sitting here with us and being not just allies. I can't tell you how many times after you get off of a panel like this, and then the person who you really wanted to say something comes up to you, thank you so much for what you said. Why didn't you say it? Right? Why do I always have to say it? Right? We need more people who are using their privilege, using their power to step up with us, because we're tired and we shouldn't have to always be tired. And maybe I'm a little more frank today because I'm tired, right? So we need more people who are willing to go beyond being allies in this work.
Absolutely. Well said. So we're going to move on to our audience questions. I have a couple here, just encouraging folks in the virtual space and in person to write down your questions for the panel and raise your hand, and one of our staff members will get those for you. So this is the first question here. UCSF Midwifery Master's Program is slated to be removed and replaced with a doctoral program. The California Nurse Midwives Association lodged a protest letter and gathered signatures. What else is being done to ensure that these programs are not removed? Yeah, right.
I'm sure that there are others who could probably speak more, but I think the answer would be unsatisfactory, and that more should be done. I think in terms of what is being done, I've seen a lot of chatter from like national midwifery groups just trying to, they have a policy toolkit to kind of help the average person be able to be more facile in talking about why midwifery access is more important. They have preset letters that you can send to your legislator. And so I think that's just one example, but I think more can be done and more should be done.
Okay. And here, this is one. Thank you, Dr. Williams. He says, with my CMQCC and Pregnancy Associated Mortality Review Committee member hats on, She would like to know how community would best like to receive maternal health outcome data. A great question. Oh, how
Why's
would
everybody looking
community
at
best
me?
like? Go ahead.
Can you say that again? How?
How would community best like to receive maternal health outcome data?
I think the way it was shared today was really effective. The storytelling and not just charts and not just pie charts and all of that, which will turn, people who don't have experience in this area will turn them away. I love the storytelling. And I think, most of the time, a lot of our effective messaging is just one-on-one conversations because I know how to reach my mother, right? I know how to reach my cousins. And so putting it in a language that folks can understand and storytelling and adding anecdotal information and anecdotal stories is a really good way to get the message across.
I get the sense that we have a really good idea how to share data when it looks good for us, right? Like we don't seem to have that same question of how we're going to get this good data out. So I would say, however we're sharing that, probably share the other data the same way.
That part.
Maybe we should do it in a rap. Hip hop style. I don't
You,
know.
Sister Alma? You get on the mic.
Whatever works,
Ready.
And also our story map will work now. Now that it's ready, it will be distributed countywide.
So the rap and the story map. That's a wrap. Okay. Okay, so we have another question. I'm gonna do this one from the virtual audience. And this person looks like they are from out of state. They say, I attended another conference and there are organizations looking at improving the healthcare for Black women through policies, making doctors more accountable for severe mortality rates of patients under their care. Policies such as losing their licenses. They're also looking at technology such as creating a hotline for women to be able to call if they have concerns. And they also have created informational podcasts for mothers. Can these same things be done in California? And this might be an opportunity for you all to shout out any particular policy or avenue that you know of in the state that does something comparable.
I can say in our county, we have an ombuds group that's been really rewarding in my experience. So it's myself and a team member of ours and the chief experience officer and our chief quality and safety officer. So now we have reports that can come through for perceived or experienced inequities, bias, what have you. And we do one-on-one connections with all folks involved, and it's really grounded in sort of restorative practice, which means every person involved is deserving of support and healing. And we specifically focus on the person that experienced the harm in terms of repair. And so that's not been in place for a long time. We've just sort of gotten off the ground with that. But just being able to connect with patients one-on-one and not giving them such a sterile response, that again goes to prevent risk. But being able to have those sort of one-on-one connections with staff members that are experiencing these issues and patients has been really rewarding. And it also helps us look at system level trends. So if we're seeing the same people, the same departments, the same units, it allows us to track that data better. So it's not, I would not say that's a system level intervention, it's an individual intervention, but one that's been impactful.
Wonderful. We understand that the best way to approach these inequities is to have a multidisciplinary approach involving various programs and practices and garnering allies that we need. How do you think we can reach these key stakeholders and bring them more to the table and get them more involved?
That's an age-old question. How do we get the people we need and want at the table? I think we just keep doing what we're doing now. We keep talking about it, we keep pressing, we keep knocking on doors. I think data speaks volumes. We can't stop, we can't let up, we continue to do what we're doing. I think we have more people at the table now than we had 30 years ago. And we've, absolutely in Santa Clara County have our local government on our side. This is something we hadn't seen to this degree ever before. So what we're doing right. It just takes time, and we just have to keep, like I said, pedal to the metal, keep going.
And then this might be our last question. One thing that may be helpful is to have physicians, nurses, medical staff, et cetera, educated on Black maternal care specifically. How can we partner with medical programs to train staff for the future and future generations of healthcare providers?
I think, it's hard. I think that it goes back to your question, how do these like groups find each other? But I will say, like, for example, at Stanford in medical education, we're incorporating ways to, talk about social determinants of health. That's actually like a class that's offered. There are formal lectures Dr. Williams and I have participated in for undergrad students, and as well as medical students in terms of talking about maternal mortality, even talking to research students, like as you think about your research question, how do you frame race? Why are you framing race that way? Do you understand that race is social, and in your data that you're going to get back, is that also going to reflect that, and that you're not perpetuating another bias, whether it was unintentional? And I think in terms of formal ways beyond just one institution, there's a lot of reform that can happen in medical education. We didn't really talk about it today, but there are some biases systemic in terms of how we've heard about pain perception that has been viewed differently because someone was Black, or in terms of dermatology diagnosis because someone is Black. Or for me, I study anemia, how if someone was Black and they're anemic compared to someone who's white, they may not get treatment because it was assumed that they could be okay at that same level. And so I think for a medical education reform is really just asking these questions. Why is race a risk factor? Are we looking at race as it is biological, which we don't believe is true, or are we truly analyzing it as social? And in terms of how partnerships can happen in the community level, I think that is a part that there are different organizations in terms of medical education who are looking to reform that. And so I think there are ways. I'm happy to talk offline about what I know about our institution, but I think that is an area that is ripe for change.
I would also say for residency programs, we're showing residents what it looks like to practice medicine. And so if we're allowing residents to have really negative experiences, we're showing them that that's what it looks like to practice healthcare. So we need to make sure we're listening to our residents, taking our residents seriously, showing them what it looks like for this to be equitable and just.
I can speak for Roots Community Health. One of the things that we've been doing is taking in residents and interns from Kaiser and from Valley Medical and other local hospitals so that they can get an understanding of what community health is all about. And then giving them the actual time to spend with patients. So it's not, every 15 minutes, but actually giving them time to spend with them, to learn who they are and experience what it means to work with communities of color. And then bringing in our navigators to speak with physicians. So we look at individual, what we tend to do is look at each patient individually, and then we have these multidisciplinary teams that we bring together to discuss what can we do? How can we help this person better? And mostly that occurs in our complex care, with our complex care patients that have multiple, social issues as well as chronic illnesses. We bring in together the, various people from within, just to discuss the case, just discuss this person's life in ways that we can make it better. This takes time, right? It takes additional time. You lose a little money, but because you're not doing that every 15-minute thing, so you lose some money, but the investment that you make into the community and to the lives of folks really, that outweighs, in our view, it outweighs the extra dollars that we would make.
As it should, absolutely. Okay. So please give a final round of applause for our panelists. Thank you, Dr. Ira, Leilani, Alma, thank you.